Thanks for the opportunity to present at breakfast. Some people don't know me, so I'm going to do a brief introduction, and I'm here to talk to you a little bit about the basic science around topical oxygen therapy. As a background, I work in Toronto, so I'm a plastic surgeon in Toronto, but I'm also the first in Canada surgeon scientist entrepreneur. So I've been hired by the university system I guess as a knowledge translator, so to bring things from bench to bedside. I work in one of the largest health organizations in Canada. We have the largest wound care group in Canada as a multidisciplinary group. And my organization at the University of Toronto is one of the largest research organizations in North America. So just to give you a sense of where I work. The hospital itself, so where we work, we're a level 1 trauma center. So we see everything from open abdomens, gunshot wounds, really actually some crazy, very large wounds. But we also have one of the largest diabetic lower extremity salvage or preservation centers. So my team really is a multi-D team, so allied health professionals, as well as vascular surgeons, orthopedic surgeons, internal medicine, infectious disease, and we all work together to try to help the patient. And we see thousands of patients a year, so not just with diabetic feet, but with wounds in general. I have a little bit of bronchitis, so I apologize for my scratchy voice. I'm clearly not going through puberty, a little older. I've been a proponent of oxygen, and I've been studying oxygen for over 20 years. Oxygen for me is the vital product that you need in a wound in order to heal it. And in fact, when topical oxygen became available 10 years ago in Canada, I was one of the first people to adopt and sort of try to figure out why does this work? And that's really what this talk is about today. Overall, for me, the advantages of topical oxygen, so just as a person who's used this quite frequently and for a long time, I like it because the delivery is 24 hours a day. You don't have to do any additional dressing changes, which in a country like Canada, that's very big, and people have to come from far away to see you. That's great. And it also means one home care visit, which our government pays for. You don't interfere with offloading. So some of other products, you might not be able to put them in a total contact cast. Definitely 100% you can TCC these patients, and we do our own custom TCCs, so even somewhat more challenging with our orthotech. I really believe it saves costs associated with those home or hospital visits, and we saw that certainly during COVID, and I think the whole world started to understand why that's important. It's easy to apply, it's small, inconspicuous, and there's no noise, and that's really important for the patient, and it helps with patient compliance, and that was a lot of feedback. They just slip it in their pocket or put it around their leg and they're fine. And then finally, it's accessible. So also, there's a concept called minimally disruptive medicine, which we practice in my clinic. We know that compliance drops when the burden of treatment is high. So most of our patients are very compliant because I find things that work within their own system and what's working for them at home. It also allows them to function normally. And so if you have a chance, this is a concept that came out of the Mayo Clinic to look at MDM, and our diabetic patients definitely experience this type of disruption. We didn't make your meta-analysis, but we did do the first RCT. But it was a powered study, but it was small. So there was 20 patients in this study. We also do a washout period. So everything we do when we're looking at oxygen, we have a 4-week washout period before we enter anyone into a study. So that's a typical protocol for most wound centers. And really the idea behind it was, could these patients with non-healing DFUs over 8 weeks duration, which in Canada, generally they come at 26 weeks. So on average in Canada, your wound's open for 26 weeks before you get to a wound center. And then we did standard best practice of care, which is the same that happens in here in the United States, as well as standard best practice with Natrox. This is, I guess, the sort of example of how we taped it. So we were a little bit innovative when we started to figure out how could we get these discs to stay. So we actually use steri-strips. So we just put little steri-strips around the edges, a foam over the top, and then get them in their TCC, wrap the tubing. Patients were well matched at baseline, so with respect to how long they had been open, as well as the total area size between control and the Natrox group, so no differences there. Also with respect to their demographics, but giving this talk very quickly, so I left some slides out. If you look at who healed or the percentage of healed chronic DFUs, and we graded them, and we use Texas grading in Canada, so I know there's UC Wagner, but we found that in those earlier grades, not really a big difference. So no difference really between the control and the Natrox group. But when you start to get into those more severe or more the deeper wounds, definitely a big difference. And we found that they all healed within these groups. So that was, I guess it was interesting to us, but also intuitively makes sense. Texas grade 1, clearly, they will probably heal on their own with best practice and standard of care if they get it at early time points. And I do believe that the Natrox made a significant difference in the healing of twos and the twos and the threes. Also, we noticed that there was rapid changes, and this is the premise behind some of the biofilm work that I'm going to talk to you about, that at 2 weeks, we started to see that the wound was rapidly starting to change, and it was both in wound size as well as the amount of exudate, as we've already talked about. The exudate, however, it's almost like the wound is dripping. And when you have the limb and they're in your chair, you can actually literally see fluid just weeping out of the wound. The dressings are actually sogged. You have to change them very frequently in the first 2 weeks. And it was my idea as a basic scientist in the beginning that this truly was about how oxygen gradients and keratinocytes were migrating based on these gradients, and fibroblasts were migrating on gradients. But when we saw this exudate, we knew that it was more than an oxygen gradient. When you see exudate like that, that's thin and clear, it usually means that the biofilm is changing. So your microbiome, your bacteria are changing. And these are the byproducts of what happens when you break apart a biofilm. And so when we saw that fluid, we knew that perhaps this was what was happening. We hypothesized that that was the case. So overall, again, all the patients healed at the end of 8 weeks, which is almost incredible if you think most of these patients were open for over 26 weeks by the time they came to see us. So just some clinical tips and pearls based on my experience. You have to do the exudate management. So just quick, if the topical oxygen is working, you're going to see the exudate. If it's dry, honestly, it's probably not working and you have to do something else first. Not for this particular talk, but we can talk about it later. You have to change the outer dressing more frequently. These wounds will get macerated. So we brought them back to change the foam. As well as with the offloading, I brought them back twice a week for TCC versus the once a week, which we would normally do. And you have to protect the skin, so it has to be cushioned, or you can get a pressure wound from the tubing. After 2 weeks or 3 weeks, your exudate is going to settle down. That was what we found in the study. You can use your dressing of choice, and you can change it every 2 days. So that's just a little bit about my clinical tips and pearls. So overall, back to thinking, okay, is Natrox or is the topical oxygen changing the wound biofilm? First thing I want to say, at least this is a very knowledgeable group, but most people talk about biofilm as something that you can see. So when you see that fibrinous debris on the wound surface, oh, I'm debriding the biofilm. You absolutely are not debriding the biofilm. The biofilm does not live in that greenish fibrinous debris. It lives below. So once you take that top surface off, the biofilm is actually within some of that granulation tissue. You can't see it with the naked eye, and you don't know if you're taking it off or not. You have to do this with specific tests. We also know that they're very sophisticated. So they're going to attach, they're going to grow together, they're going to bring their friends, and then they're going to detach when it comes to infection or if they're trying to change what's happening in their own microenvironment. If you look at it, what happens and how I explain this to people, it's like a condominium, a complex that's put a big wall around itself in a spherical way. So it initially invites all of its friends into its condominium complex. It starts to give them information called intracellular signaling or quorum sensing, where it's telling them, hey, you know what, here's our virulence factor. Let me tell you how we destroyed this other cell. And so it's sharing information. And so the bacteria are very sophisticated. It also creates an alpha dog. So there's an alpha dog in the wound. So one of the bacteria will become the general of the army. And it is giving those signals to the other bacteria, telling them what to do. And then they also have what we would call the spies. And so the spies take all of that information and they keep it and they hold it. So they are almost like the vault of info, and they stick around. So they don't ever usually go away. And then they put a force field around them with the exopolymeric matrix. So this is actually much more complicated than just simply saying, oh, there's a biofilm and I must debride it. We know it's a major barrier to wound healing, and I realize we're going through quickly here, so we'll just go through this fast. The most important thing to remember is that the biofilm is hard to eradicate. So they're resistant to antibiotics, and it's mainly because of that matrix. There's multi-species, so it's not just bacteria, but it includes yeast, et cetera. And as well, there's 1% of the persister cells. So the persister cells are the spies, and the spies stick around and have their messaging. In order to treat them, you have to attack them on multiple fronts. but not all biofilms are bad. So this is the part where I want you to pay attention about the skin microbiome. I went and I swabbed everyone here in the room, what we would find is that different areas of your body have different bacteria. So they have a different microbiome. So if your forehead, which is oily, has a different, I guess, speciation than if it's a moist, antecubital fossa, dry, and foot. So remember, every part of your body is different. And we've done this through multiple studies using PCR. So there's swabbing. Everyone knows what PCR is now because of COVID. And we do our fungi as well as our bacteria. Overall, patients with diabetes are already at a different baseline. So in diabetes, essentially, they don't have as much staphylococcus. So there's a reason for that, which we can't get in today. But in our control group, so you and I who don't have diabetes, we have a bigger population of staphylococcus. So as you can see here, what we've done with PCR has shown that people with diabetes without a wound are automatically different. So they're already behind the 8 ball when it comes to getting infections as well as healing their wounds. Again, looking to wound chronicity, topical oxygen therapy, in my opinion, should be used really at the beginning of the wound because we want to make sure that these patients who are already at a different baseline don't change to become that chronic wound and don't change to become a different type of microbiome. And we want to keep them sort of at their baseline or back to what might be normal. So then we asked the question, what effect does Natrox have on this wound biofilm? We did a similar study, again, a washout period. In this case, what we did is in the washout period, we also took swabs for PCR. So we're profiling the bacteria at each point and each stage of their journey, as well as up to 8 weeks after in their therapeutic group. When we looked at, say, a non-responder, so someone who did not respond to Natrox, what we found is that they classically stayed anaerobic. So remember, when we do these PCR tests, we're running thousands of types of bacteria through our PCR machine, and then we profile them. So what you see here in the graph, if you can see my cursor, is that they mainly stayed orange. So orange means anaerobic. Anaerobic things are, and then in the green, this is your aerobic. So this would be like Staphylococcus, Corynebacterium. This is a person who actually did not go on to respond to Natrox, but that's not why we're here. What we're here is to talk about what happens if they heal. So what happens if they respond to Natrox? So in this case, what we saw is at the beginning of week 0, we profiled their wound. They looked like a very typical diabetic, mainly with anaerobic bacteria. But as they started to use Natrox, especially around that week 2, 3, we started to see the shift in them becoming aerobic. And this is a huge, huge thing, especially in microbiology, to show that you can shift a microbiome. So I'm not telling you I cultured for one bacteria. I'm telling you these patients shifted their microbiome. And that's a really incredible thing to see because they're mainly anaerobic from the beginning. So not only did we get them from their baseline profile, we actually converted them back into something that looked more normal. So Natrox is actually helping them become more normal. And so that actually is by week 8. It's almost incredible when most studies are actually up to week 12. Change is good. And again, this is just showing over time that the microbiome is changing. If they do tend to stay in green where they are anaerobic, this is a wound that's probably not going to respond to the topical oxygen, and something else needs to change to help push that wound into an aerobic space, or it just may be that the topical oxygen is not going to work for that particular patient and something else needs to happen. In terms of the clinical impact, this is just showing you the responder versus the non-responder. And again, in green, mainly aerobic type environment is your responder. And if it mainly stays anaerobic, then it is a person who's not going to respond. And then quickly, and we don't have to go over this too much, but using non-invasive, non-contact imaging, we can do oxidant damage, that's within the foot. We looked at this also with the Natrox device. These technologies actually come from the art world, and this was a painting they thought was by Leonardo da Vinci, but the art history buffs didn't want to take the painting apart to see if he had in fact painted it, because this was also painted by Filippo Lippi, who's a very famous Italian artist. And what you can see using NIRS is below the surface is Leonardo da Vinci's painting. So the idea for taking these technologies from art and actually from space and bringing it into medicine is something that we also do in our lab. what we found here is that these devices can actually measure oxidant damage, and you sort of set that up for me in your talk. If you were a responder at week 1, we found that oxidants were detected and it was well circumscribed in the wound. So you can see that by the blue that's here within the wound. And this is just our marker, okay? So this is a reference standard for what we're looking for. By week 8, you can see our marker is showing that we have detection of oxidants. So that's the oxidant standard, but yet not much is left within that wound. So this is in a Natrox responder. And again, this is a research tool. In a non-responder, again, we see that oxidants are detected within the wound, but also in the circumference of the wound. But in that non-responder, not really seeing anything show up that continued detection of oxidants at week 8. So we know that by measuring the oxidants, and again, back to your point, that this is something where the Natrox isn't really making a move within the tissue. So it's still maybe staying anaerobic, as well as we're starting to see more damage to the tissue. So some reasons I have a lot of hypotheses around that too, but I realized that it's 7:54 and I've had to go through a basic science talk, and I'll just leave it there and we'll open up for discussion.